بسم الله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. اليوم راح نتكلم عن الانتي سايكوتيك ميديكيشنز، وشكرا البتول على هذا التفريغ تلقونه في مجركم. طيب, anti psychotics. What is psychosis? Psychosis are the symptoms that occur لما يكون عندنا excess dopamine in the brain. طيب, what are antipsychotics? معناته we want to block the dopamine in the brain. So, antipsychotics mainly act by blocking dopamine D2 receptors. In the brain, we have four main pathways for dopamine. So first, let's start with the mesocortical pathway. So the mesocortical pathway starts from the ventral tegmental nucleus in the midbrain, the ventral tegmental area, so this is its nucleus, inside the midbrain, then it goes to provide fibers to the cortex. So dopamine's function here is that it provides motivation to the individual and also emotional response. So in psychosis, we have excess dopamine. What happens when we have excess dopamine in the mesocortical pathway? This will cause us to have negative symptoms of schizophrenia, blunt affect, and so on. What about the mesolimbic pathway? So mesolimbic pathway shares its nucleus with the mesocortical, so ventral tegmental area, to the nucleus accumbens. Over here, we can also call the mesolimbic pathway the reward pathway. And in psychosis, if we have excess dopamine, this will cause the positive symptoms of schizophrenia. Okay, what about 3? We have the nigrostriatal pathway. Now this one should be familiar to you. So we start, its nucleus is from the substantia nigra, and it goes to the striatum. So the striatum and the basal ganglia. So you remember, what is the function of the basal ganglia? It is movement. So what happens when we have excess movement? We have extrapyramidal symptoms, which we discussed earlier and we will discuss later in this lecture. And lastly, the tuberoinfundibular pathway, which are fibers from the hypothalamus to the pituitary, and they're responsible for inhibiting prolactin. Okay, so can you imagine what happens when we treat psychosis? So when we treat psychosis, what are we mainly targeting? We're targeting the mesocortical pathway and the mesolimbic pathway. But as a side effect, we can't control the specific receptors that are affected. So that means we're going to have side effects and blocking of the nigrostriatal pathway and the tuberoinfundibular pathway. So when we have decreased dopamine, in the nigrostriatal pathway. What does this remind you of? Parkinsonism. So we have resting tremor, we have intention tremors, shuffling gait, and muscle rigidity. These are nigrostriatal pathway. And if we block dopamine, the tuberoinfundibular pathway, so that means we have no inhibition of prolactin, which means this should be like increased prolactin. So that means we can expect that there would be galactorrhea, maybe gynecomastia in males. So this is mainly the 4 dopamine pathways. Okay, now let's go into the lecture. So we're going to be talking about antipsychotics. So we have first generations, also known as typical antipsychotics, and second generation, known as atypical antipsychotics, even though today second generation are more commonly used because of their more tolerated side effects. So remember that first generation, they're associated with neurologic side effects, whereas second generation have metabolic side effects. And over here, first generation or typical antipsychotics, they act primarily by blocking dopamine or D2 receptors, but they also have slight activity on muscarinic and histamine receptors. Whereas atypical or second generation antipsychotics, they block both dopamine and serotonin receptors at a substantial level. So, okay, let's start. First generation antipsychotics, they're the first line for schizophrenia and other psychotic illnesses. They're rarely used in hospital, but historically, firstly introduced in the 1950s, the first drug, phenothiazine chlorpromazine, was introduced first. They are also known in textbooks as DRAs, dopamine receptor antagonists, and they include all the antipsychotics. These are their names: phenothiazines, butyrophenones, thioxin, dihydro, whatever. Okay, I think you get the gist. احفظوا هذه الأسماء أو be familiar with them لأنها شوية مهمة. So you might be asked to like an example of a medication and then which of these medications is most related to it. So تعرفون إنه كلهم من نفس النوع، كلهم dopamine receptor antagonists. Same as قلنا, they are typically associated with extrapyramidal symptoms, which are first acute dystonia, akathisia, Parkinsonism, or sometimes referred to as pseudo-Parkinsonism. And lastly, tardive dyskinesia. Okay, so when are dopamine receptor antagonists most effective in treating psychosis? When approximately 72% of dopamine D2 receptors are blocked. So here is a key term, potency. Potency refers to the amount of the drug that is required to achieve therapeutic effects. So this is based on how much of the D2 receptors they occupy based on their effect, and not directly related to their efficacy, so if they're good for treating the disease itself. So if we have a drug that has a small dose that causes a significant effect, we call this a high potency drug. So what are some examples of high potency drugs? Or let's start with low potency, okay? So low potency drugs, we have chlorpromazine and thyroidazine. They are given in doses of 100 milligrams per day. 100. هذه احفظوها زين. طيب. And they typically produce more weight gain and sedation. لأنهم they're not يعني ما عندهم, they don't block most of the D2 receptors. Whereas high potency agents such as haloperidol and fluphenazine, they're given in smaller doses, less than 10 milligrams per day. هذه احفظوها مرة زين إن high potency drugs 10 milligrams per day. يعني لو سألناكم مثلا which dosage is incorrect, مثلا chlorpromazine 100 milligrams per day, lithium 1000 milligrams, haloperidol 100 milligrams. تقول haloperidol ليش؟ نعطي 10 milligrams per day لأنه high potency. Why do we use like such a low dose? It's because high potency agents are more likely to cause extrapyramidal symptoms. Okay, all dopamine receptor antagonists are well absorbed with oral administration, but we can make liquid preparations for more efficient absorption. And these liquid preparations are either intramuscular or IV, but mostly we depend on oral tablets. Peak plasma concentration is usually reached 1 to 4 hours after oral administration. But if we use parenteral administration, it's achieved from 30 to 60 minutes. So, plasma peak concentration matters because it depends on how fast you want the therapeutic effect. For ER patients, you want quicker effects, so you would go with the parenteral administration. But if it's a maintenance dose, if it's a maintenance treatment, it's fine using the oral medication. Okay, here are some factors that may interfere with the absorption of these drugs: smoking, coffee, antacids, food. So smoking, not nicotine, because we're talking about the smoke you inhale. So اللي يدخل الفم نفسه. And these affect the pH, so they interfere with the absorption. Steady state levels are reached approximately 3 to 5 days. After that, you may تحكمون على الدوس وتغيرونه حسب اللي تشوفونه يحتاج. And the half-life of these drugs is approximately 24 hours, so they are quickly eliminated. طيب, indications: acute psychotic state, psychosis, schizophrenia, acute and maintenance, mania and maintenance, depression with psychotic features, delusional disorder, and usually used as adjunctive therapy to enhance efficacy. Substance-induced psychosis, delirium, dementia. So it's symptomatic treatment in delirium because the main treatment is to find the underlying cause and managing that. Mental disorder caused by medical condition, pervasive development disorder, Tourette's disorder, mainly for the movement disorders associated, like the dystonia and repetitive movements. So we block that hyperactivity. And Huntington disease, also for the dystonia and movements. So it can be also used for symptomatic treatment in Cushing syndrome. Now let's see some over here. Haloperidol and fluphenazine. They are available in long-acting intramuscular forms, and because they are long-acting, these are helpful with patients who are poorly compliant with oral medication. هذول they are the cheaper option وفي more expensive options. طيب, let's go over the drugs واحد نتكلم عن أهمهم. So, low potency typical antipsychotics. So they have a higher incidence of antiadrenergic, anticholinergic, and antihistaminic side effects compared to the high potency equivalents. They have more lethality in overdose because they have QT prolongation, heart block, and ventricular tachycardia. Plus, there is a rare risk of agranulocytosis, but there is another medication نتكلم عنه بعدين which is famously known for agranulocytosis. And they have a slightly higher seizure risk than high potency ones. طيب, we have two main ones هنا. اثنينهم associated with eye problems. So لما تفكرون low potency فكروا بمشاكل العيون. What are these? First, chlorpromazine. Chlorpromazine commonly causes orthostatic hypotension. Chlorpromazine هو اللي first discovered. Okay. Chlor يذكركم بإيش؟ color. So هذا شيء مهم, and it can cause blue-gray skin discoloration. يشبه هذا. It occurs in the sun-exposed areas, and it's kind of like photosensitivity, بس يخلي في pigmentation of the skin. And another thing, حرف C, chlor, it could cause cholestatic jaundice. But the most characteristic thing, very high يلزمكم تعرفونه, yes, that it causes corneal and lens deposits. So, chlorpromazine, the side effect's pretty easy. Chlorpromazine, corneal lens deposits, corneal deposits. وهذا هو شكلها over here. What about the other one? Thyroidazine. This one, قلنا مشاكل العيون اثنينهم. So this one is associated with retinitis pigmentosa. So the T over here, retinal deposits. زي ما تشوفون كده. هذا أهم شيء. Yes. Looking for طيب mid potency. ما في شيء معين أشوفه. Okay. High potency. So high potency قلنا they have greater affinity for dopamine receptors. So we use lower doses. They have less sedation, less orthostatic hypotension, and less anticholinergic effects. Why is that? Because they mainly affect dopamine, unlike the less potent ones. Because they affect dopamine mainly, they have a greater risk of EPS. طيب. First one, haloperidol. Haloperidol قلنا إنه عنده intramuscular long acting version واسمه deconate. So okay. Deconate is used لأنه عنده less side effects, but again there's the risk for extrapyramidal symptoms. So عشان تحفظونها deconate long acting because deconate زي decade يطول. So عقد. وبعد okay. They may block cardiac potassium channels or prolong the QT interval. مع أنه قلنا إنه low potency ones they have a higher risk. This QT interval prolongation is strongly associated with IV haloperidol. Also, we have flufenazine. نفس الشيء deconate. هذول mainly اللي نبغى نتكلم عنهم. في هذا it's another one. Oh, my bad. Let's cut this ونحطه بعدين. Okay. So, QT prolongation. How are dystonia and akathisia treated? So, first line treatment of dystonia, benzotropine, the antimuscarinic, diphenhydramine, the antihistamine can also be used. The first line treatment for akathisia is first decreasing the dose or adding propranolol. So medication-wise, propranolol is first line or a benzodiazepine, which is second line. طيب هنا زي ما قلنا إنهم they act atypicals on multiple receptors. هذه إعادة مرة ثانية. أوكي. وهذه مراجعة سريعة عشان تذكرون side effects. So, what are antimuscarinic side effects? Dry mouth, constipation, urinary retention, blurred vision. What are alpha-1 blockers side effects? Orthostatic hypotension. Antihistamine side effects, weight gain, sedation. Dopamine قلنا EPS. هذا in the nigrostriatal pathway. And the tuberoinfundibular pathway, hyperprolactinemia in females, meaning they'd have galactorrhea, breast soreness, amenorrhea, also very important, in males, impotence and libido. And in severe cases, ممكن neuroleptic malignant syndrome, if you remember what they were, fever, altered mental status, severe rigidity, and autonomic dysfunction. Then we're going to QT prolongation. There's a risk of seizures and the corneal and retinal deposits. Corneal by chlorpromazine and retinal by thyroidazine. Okay. So sedation, meaning can be used for insomnia, decreased seizure decreased seizure threshold. So it's not contraindicated, but we need to take into consideration if the patient has a susceptibility to developing seizures, like an epileptic patient, alcoholic, having intracranial hemorrhage, encephalitis. So we have to keep this in mind. So بعد the cardiac side effects, the prolonged QT interval, they are more common than SSRIs. So انتبهوا لهذا الشيء, and they can cause arrhythmias. وهذه الأشياء about side effects, anticholinergic side effects, which are more seen in what? The low potency typical antipsychotics. Postural hypertension, because we can block the alpha-1 receptors. We also have hematological side effects, neutropenia, rarely agranulocytosis. These are more common in the low potency ones. Blockage of dopamine in the tubulointerventricular pathway, hyperproteinemia, and sexual side effects less than SSRIs. Okay, يمكن يسأل إيش the most يأثر على sexual, it causes sexual dysfunction the most? SSRIs. Pregnancy, take with caution because they could cause metabolic disturbances, maybe abnormal fetal growth, preterm birth, congenital anomalies. So you can't say that it's completely contraindicated or that it's completely safe. Just take it only when really needed and as low as possible, and recommended to use the second generation atypical ones. وقلنا neuroleptic malignant syndrome. مراجعة neuroleptic malignant syndrome, it is potentially fatal if not treated, can occur at any time, more with first generation. It is more delayed, so ممكن يجي مو in a few hours في البداية, ممكن يجي بعد يوم. So symptoms include extreme hyperthermia. Okay, 3 main domains. يشبه serotonin syndrome. Autonomic instability, neuromuscular side effects, and cognitive deficits. So in neuromuscular بنلاحظ فيه hyporeflexia على عكس السيروتونين syndrome اللي فيه hyperreflexia. Lab findings, وهذه مهمة للcase scenarios, include increased white blood cells, increased creatinine kinase, increased liver enzymes, plasma myoglobin. كل هذه because there is severe rigidity causing the muscle to break down. وممكن يكون occasionally associated with renal failure. Because of an excess breakdown, you see they're filtered out, it's too much on the kidneys, renal failure. So the symptoms usually evolve من بعد يوم, over 24 to 72 hours. Untreated syndrome can last from 10 to 14 days. This is why it's dangerous. So, onset of these side effects, neuroleptic malignant syndrome can occur at any time, but usually early in treatment. Acute dystonia, hours to days. Parkinsonism, akathisia, days to weeks. Tardive dyskinesia, months to years. The abnormal involuntary movement scale can be used to quantify and monitor for tardive dyskinesia. كل هذه في psychiatric emergencies lecture. طيب, so بس مرة ثانية, the receptors affected, low potency, they have more non-EPS effects, so sedation and dry mouth, and even weight gain. High potency, EPS effects. حطيت هذا بالنص. Continuing neuroleptic malignant syndrome. Who is at risk? Males, young, black, Sorry, tall, dark, and handsome people. طيب, high potency medications and use of typical antipsychotics more than atypical. So how is the treatment? Discontinue the antipsychotic medication. We need medical support first because there's hypothermia. We're going to cool the patient. دائما لما يجي patient فيه hypothermia أهم شيء نسوي تبريد. هذا the first step in emergencies. بعدين نسوي monitoring, heart rate, blood pressure, vital signs, electrolytes, fluid balance, and renal output. So we'll administer IV fluids to protect against renal failure and adjust the electrolytes to prevent acidosis. So a symptomatic treatment of fever or the Parkinsonism, anti-Parkinsonian عشان الرigidity. Treatment should usually be continued for 5 to 10 days, even if the symptoms disappear, just to be extra sure. 5 to 10 days. When drug treatment is restarted, the clinician should consider switching to a low-potency drug or a serotonin dopamine antagonist. هذا هو اسم atypical antipsychotics. So always هذه القاعدة, dose gradually, monitor closely. خلصنا كذا للفirst generation. الحين نتكلم عن second generation antipsychotics. So ليش هي more commonly used؟ لأنها they have favorable side effects. ما عندها extrapyramidal symptoms. أو إذا عندها فهو أقل. Greater effectiveness for negative symptoms. So in first generation, more effective for positive symptoms. In second generation, more effective for negative symptoms. And they have mood stabilizing effects. They can be used in bipolar or depression disorders, so mood disorders. They're called atypical because they affect multiple receptors, serotonin and glutamate, in addition to dopamine. عشان كذا يقدر يفيدنا في حالات غير السايكوسيس. طيب, هذه الميديكيشنز. olanzapine من ال highest potency drugs. فنفس القاعدة الأولى, high potency معناته الدوسing يكون قليل, 5 milligrams to 20 milligrams. Quetiapine, on the other hand, which is also a mood stabilizer, تتذكرون وقلنا نتذكره by quiet time, هادي, ضعيف, مسكين, low potency. معناته إيش؟ نحلبه أكثر, more dose, higher dose. So بس حطيت هاي الصورة عشان أتذكر. وهذه تفيد في شيئين, عشان تعرفون إن الكوتايبين low potency فناخذ منه أكثر, مش كذا نحيف مسكين. Whereas clozapine وolanzapine هم they have their privileges, لكن ما استخدمهم كثير, متكي عادي, هم high potency. وشيء ثاني للside effects, so عشان تذكرون clozapine, olanzapine, quetiapine, كل الحروف هذه دبة. طيب, فهذول الميديكيشنز they cause weight gain and more metabolic syndrome. بس عشان الكوتايبين quiet ومسكين فهو less side effects, هو less, هذولي more. طيب, we also have من medication risperidone and risperidone, نفس الشيء. So we have different types, tablet, liquid, injections. They make هاي medications and they are less sedating and good for elderly. مات الواحد يصحى بدري. So risperidone, rise and shine and wake up early because the patient is less sedated. Paliperidone, نفس الشيء, tablets or long-acting injections. ولأنها long-acting We give them every 1 month or 3 months. طيب aripiprazole. This is a newer medication, and الميزة إنه it has less side effects. It has less side effects, but مشكلة it's not always effective. But we usually start it as a first medication لأنه less side effects. الشيء الوحيد اللي ممكن concerning فيه إنه it causes akathisia the most out of any of these medications. طيب هذول medications كلهم if they fail and we have resistant psychosis, in cases of resistant schizophrenia or any condition, we go to clozapine. It is very potent, and the reason why we keep it only for resistant conditions هو لأنه عنده severe side effect اللي هو agranulocytosis. So agranulocytosis فيصير نحتاج we monitor الCBC. أول ما نصرف الدواء يصير نتابعه weekly لأول 6 شهور، بعدين بعد هاي 6 شهور نتابعه bi weekly هذه 6 شهور، بعدين monthly for life. Weekly first 6 months, bi-weekly next 6 months, and then monthly for life. هذا protocol for monitoring the CBC. طيب تذكرون في mood stabilizers what medications also cause agranulocytosis؟ واحد منهم يبدأ also بحرف السي اللي هو carbamazepine، والثاني lamotrigine. طيب so الحين نشوف من first aid. Atypical antipsychotics block both dopamine and serotonin receptors, or glutamate also, less likely to cause extrapyramidal symptoms and neuroleptic malignant syndrome. They may be more effective in treating negative symptoms. So هذه seen in practice. بس طبعا كل الأشياء اللي نلاحظها ما هي مرة مثبتة. They're based on theories or they prove to be effective. عشان كذا نسويها. Atypical antipsychotics are also used in treatment of acute mania, bipolar disorder, adjunctive medication, and unipolar depression. كل هذه من حالات المود stabilizers واللي كنت أتكلم فيها عن الquetiapine. They're also used in treating borderline personality disorder, PTSD, and psychiatric disorders in childhood, tic disorders. طيب نتكلم عن أهم الأدوية. Clozapine, even the most potent, so it's less likely to cause tardive dyskinesia. The only psychotic to be shown to be more efficacious than the others. It's used in treatment of refractory or resistant schizophrenia. It decreases the risk of suicide. So تشوفون like, wow, this looks really great. But نبدأ الحين بside effects. It has more anticholinergic side effects than any other atypical or high potency antipsychotic. So associated with tachycardia, constipation, hypersalivation. The risk of severe side effect اللي هو agranulocytosis is 1%. فمتى نقول إنه we need to stop clozapine? Clozapine must be stopped if the absolute neutrophil count drops below 1,500. هذا رقم مهم. الاختبارات هي أو كذا. ونفس الشيء اللي قلنا المونيتورينج الطريقة هذه. Okay. There is a 4% incidence of seizures and a small risk of myocarditis. So it's really great. We love your vibe clozapine بس بنخليك شوي على جنب. طيب نروح للريسبيريدون. ريسبيريدون أو ريسبيريدال هو اللي قلنا إنه it's great for elderly. It's less sedating. الواحد يصحى بدري. Rise and shine. But rise and not so shine because it also gives rise to a pair of breasts. So risperidone causes increased prolactin and interestingly gynecomastia. So remember this, and gynecomastia. It's associated with orthostatic hypotension and reflex tachycardia. Okay, quetiapine, less likely to cause EPS. Common side effect, quiet time, يعني حان وقت النوم, sedation, orthostatic hypotension, and weight gain. تذكروا حرف الكيو دبة, weight gain. Olanzapine, it causes significant weight gain. So, هاي الصورة olanzapine. It's the most that resembles an like obese build. So weight gain, sedation, dyslipidemia. Ziprasidone, وهو اللي we cut before. So مقارنة بالatypical مقارنة بالtypical antipsychotics, QT interval prolongation occurs less in the atypical ones, but there still is a risk. وهذا الrisk is in ziprasidone. So ziprasidone is less likely to cause significant weight gain, but it's associated with QT prolongation. Aripiprazole, so its unique mechanism is that it is a partial D2 agonist, عشان كذا عنده less side effects ذكرناها, but it is more activating of akathisia and less sedating. فهو partial agonist, فهو النص بالنص, نص دوبامين نص سيروتونين, عشان كذا ممكن يستخدم بعد as an antidepressant. الباقيين not so important. So هذه side effects also, بس بنضيف إنه الهستامين side effects, weight gain, sedation. Actually هذه شكلها ذكرناها. Okay, ذكرناها هذه لكل المراجعة. So side effects, metabolic syndrome, olanzapine, quetiapine, clozapine. ذكروا كل الدوائر. So extrapyramidal symptoms and hyperprolactinemia, they are more common in risperidone, specifically إذا الدوز حقنا زاد عن 6 milligrams. So risperidone, more EPS, more prolactin. هاي قلناها. قلنا الakathisia, first line treatment, reduce dose of the medication, and for medical treatment give propranolol. Clozapine, هذا النموذج كتبونه. So clozapine, you watch it closely for agranulocytosis. بس أسألكم بس تحفظونه. نفس كل هالأشياء قلناها. إحنا 1% من first aid هنا مكتوب 0.3% during the first year. والcommon side effect لهذه المedications هي postural hypotension, sedation, and salivation. So إذا حس بالpostural hypotension إيش نسوي? Do we stop the medication? Do we switch it? No. We give advice to the patient. So إيش مثلا نقدر نقول له؟ لما تقوم من السرير تمسك بالطرف, تمسك يعني الحافة, وقوم حبة حبة عشان ما يحس بالدوخة هذه. So عشان تتذكرون olanzapine, metabolic syndrome, ziprasidone, QT prolongation, risperidone, highest risk of EPS, and gynecomastia. Clozapine, agranulocytosis. Quetiapine, it's quiet, very lowest risk of EPS, used in patients with movement disorders, and a mood stabilizer. Aripiprazole, قلنا يسوي akathisia, which is restlessness, but it can also present as loss of impulse control. فممكن يكون هذا patient والله يصير عنده gambling addiction. Patient should be aware of that. هذه references. طيب الصفحات لسه باقي 60. That is because I have for you questions. Yes, I do. طيب أسئلة أمباس تغطي هالموضوع زي الفيديو اللي قبل. بعطيكم a few seconds عشان تقرون السؤال وتجاوبون. So pause if you need. 3, 2, 1. السؤال هنا كان إن a patient has involuntary movements of the tongue and face. They are slow rhythmic perioral movements. So هذه هي tardive dyskinesia. وإذا تبون فيديو له بتلاقونه في فيديو psychiatric emergencies. طيب هذا السؤال اللي بعده. 3, 2, 1. So patient takes short quick steps, difficulty maintaining balance, increased resistance to passive movements. هذا البيشنت عنده pseudo Parkinsonism. طيب هذا السؤال اللي بعده. 3, 2, 1. So هل patient has psychotic symptoms and he was taking treatment for this. بعدها 1 week later صار عنده difficulty walking, tremor that improves with activity. So هذا dopamine antagonist. الحين أتذكر كان أنا قلت intention tremor كان قصدي resting tremor. Anyways. السؤال اللي بعده. 3, 2, 1. So patient has repetitive lip smacking, dance-like movements. هذه tardive dyskinesia. Switched from fluphenazine to risperidone and his symptoms improved. So why is that? Risperidone تذكرون قلنا عنده less EPS. Fluphenazine هو first generation antipsychotic, risperidone second generation, and من second generations عنده less EPS. So الإجابة weaker dopamine receptor antagonism. طيب السؤال اللي بعده. 3, 2, 1. Patient taking treatment for schizophrenia and erectile dysfunction. ليش? Because they have decreased testosterone levels. Because let's read another. So dopamine antagonist قلنا إن هما they increase prolactin, and increased prolactin will affect the HPA, causing decreased testosterone. طيب هذا السؤال. 3, 2, 1. So patient on olanzapine. What is the most likely adverse effect? So olanzapine, semine, metabolic syndrome. السؤال شوي طويل. So actually بعطيكم الخيارات عشان تختارون منها. Okay. 3, 2, 1. الجواب هنا. Let's نشوف السؤال. So the patient هنا عنده dyslipidemia, is developing diabetes. So إيش medication that they should consider discontinuing olanzapine نفس السبب metabolic syndrome. طيب أعطيكم هذا السؤال الحين. 3, 2, 1. الجواب clozapine because clearly مكتوب laboratory studies show agranulocytosis. Okay. 3, 2, 1. Feeling restless because of treatment with flufenazine. So first generation, we're going to expect extrapyramidal symptoms. Which one of these is basically feelings of restlessness? Akathisia. Okay. Laboratory reveals moderate hypokalemia and hypomagnesemia. صح ما في سؤال جاي عليه صريح بس this could help you. Which of the following should be conducted before or and during this patient's use of haloperidol? 3, 2, 1. And ECG because of the risk of QT prolongation. Okay. 3, 2, 1. إجابة clozapine because من المedications هنا نقدر نشوف إن من اللاب results هنا leukocyte count. This is below 1500. بعضهم this is below 1500 so this helps us determine that it is agranulocytosis, clozapine. Okay, هذا السؤال تكرر. 3, 2, 1. Tired of dyskinesia. Smacking lips, twisting movements. Risperidone. What is the increased risk? 3, 2, 1. Gynecomastia. Because it gives rise to a pair of breasts. هذا السؤال بالغلط. قدرنا screen shot السؤال نفسه بس let's see it. So, patient with altered mental status, confused. Pretty cool. Like, he was started on a new medication. He is lethargic. He has absent deep tendon reflexes. The pupils are dilated, poorly reactive to light. What does this indicate to you? So ليش apartment cold؟ لأنه هو كان حران. إيش نفكر فيه؟ Neuroleptic malignant syndrome. Let's see the options. Which of the following medications is the most likely cause of these? Flufenazine, because it is a first-generation antipsychotic, increased risk of neuroleptic malignant syndrome. This is a double question. Okay. 2 weeks after hospitalization. Oh wait, I'm sorry. خليكم تقولون السؤال. 3, 2, 1. Okay, so patient was taking flufenazine, shuffling gait, rigidity. هذه كلها pseudo Parkinsonism. Treatment with drug is most likely to provide relief to this patient. Muscarinic antagonists. هذه main treatment of Parkinsonism. Three, 2, 1. سؤال تكرر and it's akathisia again. آخر سؤال. Which of the following diagnostic tests is indicated to evaluate for a potential adverse effect of using haloperidol and ondansetron in combination for the treatment of nausea? Do you remember what ondansetron is? This is an antiemetic. 3, 2, 1. And ECG. So antiemetic functions through serotonin antagonism and dopamine antagonism. So this medication affects D2 receptors as well in the brain because D2 receptors are in the vomiting center in the midbrain. So dopamine antagonism can prolong QT interval. So أول ما تشوفون haloperidol also can prolong QT interval. أول ما تشوفون سؤال يسأل how do you evaluate think ECG. ECG very important when using antipsychotics. وكده خلصنا.